Hello, everybody. My name is Salrin. I want to first and foremost apologize for not being here for a live session. I am currently out of the country and I will be traveling during the conference. So I just wanted to thank everybody involved for the flexibility and the opportunity to share with you all. So show you what I've been up to in Colorado for the past year. I do want to start off by saying, because I'm not here live with you guys, if there are any questions that come up, since we won't have a formal Q&A, keep an eye out for my email in the last slide. Feel free to reach out. If you have any questions, comments, want to learn more about it, I'll be happy to get back to you pretty quickly. With that being said, we can dive right in. The United States has the most expensive healthcare system in the world. We're talking per capita health expenditures far above those of any other nation. For many years, the U.S. healthcare expenditures have been growing pretty far above the overall rate of inflation within the economy. The few experts and economists have argued that the high and rising costs are not such a serious problem. Most observers disagree with that view, though. As healthcare professionals, we inherit an obligation to represent these individualized efforts, however small, to best address these changes. But the question still remains, how? How is a staff nurse supposed to have the tools and the resources to tackle a worldwide issue such as the extensive healthcare expenditure? I'm not talking about a director or a chief nursing officer affecting change or even a nurse manager. I'm looking at what perspective and efforts a staff nurse can do to impact change. For me, this was having a platform such as this to spread the data collected through my role as an operating room nurse. Cost cutting is difficult in any industry, but it's particularly challenging in healthcare, where these organizations are simultaneously undergoing major transformations to both improve healthcare and the patient experience, right? So in a hospital setting, cost reduction can often be equated with cutting corners. And so it's perceived as this inconsistency to the provider's values. Typically, this can create high levels of employee and patient dissatisfaction. So resetting the health system's cost structure also implies a greater centralization and standardization. And this goes against the grain, really, of these local facility leaders and clinicians. But what if there was another way? It was clear to me that my impact on my organization was not going to be implementing the monumental change to the organizational structure. I did, however, realize that a focused project could still combat the contributing factors and impact change. I was lucky enough to be given this project that was originally and purely focused on patient health outcomes, and then expand that to include the broad and overwhelming issue of healthcare costs. So getting this project to become sustainable, both short and long term, is done through the affected outcomes. But the impact beyond one facility into a nationally applicable cost effectiveness strategy, now that's done by creating a pairing between cutting expenses while not having to necessarily sacrifice these positive outcomes. Being a staff nurse myself, I know the power or the lack thereof a single person can present in the $4.37 trillion healthcare industry. I have always been one to personally advocate for maximizing the resources available, but really that can only get you so far. It creates this gray space, this gray area with the potential to compromise outcomes. Finding a solution for the relationship between cost reduction and improving outcomes for this project was done by focusing on the long-term investment that a quality improvement measure could potentially create. It's easy for us to look at any given product, especially in healthcare, and assume its indications through marketing, our own experiences and training, or predispositions, right? If we look past those initial cost comparisons and those factors and get into the why of process and product improvement initiatives, new possibilities can arise, right? Such as unexpected beneficial outcomes that directly affects costs. Now, unintentionally, but it still directly affects those costs. So in our operating room department, our peri-op department, that quality improvement measure was simply equipping patients with a new dressing. The standard compressive dressing we were applying to every total joint replacement surgery was an Aquacel dressing. The Aquacel is a pliable, water-resistant bandage that remains on for 1 week post-operative. It's then removed to apply an additional one for another week. The Aquacel is also used for total complex joint replacements, revisions, as well as irrigation and debridement surgeries. The dressing is universally accepted by U.S. facilities and researchers to assist in infection prevention through a silver-infused gauze layer that topically combats superficial bacteria. The opposite side of your screen is the dressing that we introduced for this experiment. It is the Pico dressing by Smith & Nephew. The Pico is similar to the Aquacel in that it's also water resistant, but it is additionally a negative pressure wound therapy dressing. What that means is these dressings act as a vacuum and then therefore affect the modulation of inflammation, angiogenesis, granulation tissue formation, wound contraction, perfusion, as well as the reduction in bacterial colonization. It's advertised as an improvement over a standard compressive dressing in surgical site infections by mitigating and targeting not only the superficial infectious particles, but also potentially the deeper bacteria through the vacuum and the increased perfusion to the surgical site. In addition to these properties, the Pico dressing also has a specific membrane that will actively wick away moisture and exudate it through the dressing's top layers via evaporation. This will allow the dressing itself to not retain any excess fluids or amounts of fluids. Therefore, it's avoiding that external canister, that fluid canister that accompanies just about every other negative pressure wound therapy dressing. But it is important to note that the Pico dressing, did not invent the negative pressure wound therapy concept. Plenty of alternatives do exist and have been successful in the U.S. medical market. But what's unique about this solution, the reason why we went this route for this project, is that there's a decreased burden on the patient with that absence of the external canister. It's convenient for the patient to wear it. Other dressings require these complex systems and many more parts, both an inconvenience for the wearer, but also naturally being more expensive to produce and resell. So these expensive and bulky alternative dressings negate the original premise of the project, was to look into cost-effective options that increase the satisfaction and positive outcomes for the stakeholders. The Pico dressing is about half the cost of the closest competitor and exceeded all alternative dressings in a side-by-side comparison. So that's kind of the rationale on why we went that route and went with this dressing. So now you may be wondering, after I listed off the extensive benefits over standard compressive dressing, the outcomes are better, obviously, but how does it save money? So the truth is the Pico dressing is dramatically more expensive than the Aquacel. It's 7.5 times more expensive, to be exact. Yet we saved, on average, over the whole study, $1,635 per admit when the PICO dressing was used. Remember, the purpose of the study was not only to maximize the outcomes for patients, but also to cut the facility's costs without compromise. So this was achieved by appropriately targeting the indicated patient populations. When appropriately applied to only high-risk patients, the PICO dressing was responsible for a $2,400 savings per admit. These numbers are coming with a clear benchmark. We considered patients to have an ASA score above 3 or higher to be designated high risk. So when I say high risk patients saving $2,400, I'm referring to an ASA score of over 3. For those who are unfamiliar, an ASA classification tool is a system in the US for assessing the fitness of patients before surgery. It stands for the organization that developed the tool, the American Society of Anesthesiologists. And a score above 3 basically indicates that a patient has one or more moderate to severe systemic diseases. We consider that poorly controlled diabetes, hypertension, COPD, or a BMI over 40. I also want to clarify that the Aquacell works great for the majority of our patient population, especially for total joint replacement surgeries. There was a significant variation, unpredictability, however, in the outcomes, such as healing time due to seroma formation, skin integrity, inflammation, and surgical site infections. The PICO dressing addressed those areas, thus decreasing admission time. The average PICO cost to the patient per day for a hospital admission was around $3,949 in the United States. My specific facility packages those rates at $3,000 per day. So that's going to be kind of the benchmark metric for all the data you're going to see presented in this study. With the permission of my facility, I was able to conduct an internal study with a total of 50 participants for the initial phase. All patients had their surgeries conducted at Broomfield Hospital. 25 patients were equipped with an Aquacell dressing during closure, and 25 were equipped with a PICO dressing during closure. All the participants were admitted following their total joint replacement. Age, BMI, ASA score, diabetic status, whether or not it was a revision or a primary surgery, those were all indicators that we recorded for each case. There was also the opportunity to recently apply both dressings to the same patient when a bilateral total knee replacement was conducted. So with this in mind, what are we looking for exactly, right? We're tracking specific outcomes at the 2, 6, and 12-week intervals, as well as the overall cost that's transferred to patients based on their admission time. Specific outcomes we aim to improve were the mobility, the comfort, lateral tension scarring, inflammation, and as well as healing time. Dr. Michael Dayton and Dr. Jared Pate of UC Health were identified as the independent primary stakeholders in the integration of the negative pressure wound therapy PICO dressing trial. Each clinic provided cases towards the experiment and the control group's goals. Tracking was provided in part by stakeholders in the form of follow-up appointments at 2, 6, and 12 weeks. Participants were invited to participate in this project during their initial visit. At the time, they were explained the goals and procedures, as well as their obligation to provide feedback for their experiences. Upon commencement of the surgery, the Aquacell dressing, being that it is a standard compressive dressing, gets applied without much complexity. The knee does, however, have to be bent at a 45-degree angle. The Aquacell, the reason why is because it doesn't stretch well, right? And if applied at 0 degrees flexion, the discomfort of lateral tension pulling at the skin prohibits the ambulation, or at least makes it extremely difficult and painful pulling on the skin. And so that ambulation is an essential step to early therapeutic intervention for total knee replacements. The patient would then wear this for 7 days, remove that dressing, and then reapply a second Aquacel for an additional 7 days. The Pico dressing, on the other hand, would get applied to the knee at any position, as the material is a lot more prone to stretch and form to the extremity. However, the Pico dressing, it's not as intuitive. It does require specific order of application, as well as reinforcement strips along the edges for the vacuum seal. So the vacuum pump is attached before leaving the OR and will automatically shut off after 7 days. At that point, the patient could then remove the dressing and they would not require a second one. I had reviewed each case at the 2nd, 6th, and 12th week follow-up appointments, as well as reached out to the participants for a feedback interview and a request for photos to assist in the scar formation analysis. Post-surgical complications related to the dressing were then recorded at that 2-week follow-up visit. The initial comparative findings showed that patients who were equipped with the Pico dressing were consistently discharged faster than the Aquacel patients. The average Pico participant was discharged 0.9 days faster than the Aquacel average. There was also a decrease in surgical site infections for the 2 clinics during the study period. Utilization of the Pico dressing resulted in an average of all the participants a $1,635 cost savings. But again, that increased to $2,400 per stay when we only applied it to those ASA scores over 3. Post-surgical complications were twice as great for an Aquacel patient as compared to a Pico patient. The Pico dressing had a 7.7% complication rate, while the Aquacel reported a 14.3% complication rate. 2 of those Pico dressings had vacuum seal failures at some point throughout the 7-day period. At the point of a vacuum failure, by the way, a Pico dressing basically will just turn into a standard compressive dressing. It does not require replacement necessarily. Without the vacuum, it's just kind of a typical Band-Aid or what an Aquacel would serve as. 4 instances of severe redness and skin breakdown were noted with Aquacel dressings, though, and that contributed to their complication rate. But what's interesting is overall, out of everybody who had an Aquacel dressing, 33% of them complained of extreme discomfort during the removal. A statistical analysis was conducted to identify any possible correlations and or causal relationships between parameters such as age, BMI, ASA score, and admit time. The only observable parameter consistently influencing improved discharge time was the type of dressing. So this strongly suggested to us that there's a causal relationship going on between the type of dressing and admit time, and that's the only thing that seems to be within a pattern here. Referencing back earlier to the bilateral total knee replacement with each dressing applied, significant edema was observed on the Aquacel applied knee 1 day post-op. The patient reported increased perfusion and less swelling to the Pico dressing applied knee. And then in the 2-week follow-up appointment progress note, Dr. Dayton noted that there was paresthesia in the infrapatellar branch of the saphenous nerve on that Aquacel-equipped knee. The same progress note described lasting tenderness and swelling over her tibialis anterior muscle on that same side. And that's all referencing that image you're seeing in that current slide. Even visually looking at it through a recorded PowerPoint, you can tell there's a difference between those two in the swelling, in the scar already at 2 weeks. So yeah, it's pretty interesting. Multiple participants in the study group had previous experience with the Aquacel, and so they were able to make these direct subjective comparisons. I'm not sure if you can see them, how big your screen is, so I'll read them to you. They said physical therapy was easier because the Pico stretched. And then compared to the last time where with an Aquacell, the incision looks like it's had a month's progress in a week. And then the last one is, I remember my last knee replacement had worse swelling. So feedback was encouraged from all participants during the 2-week follow-up phone call. Common patterns from all feedback was centered around the complaints from raw and red skin following the removal of an Aquacell dressing, the tightness and the restricting feel of an Aquacell dressing, as well as noting how the Pico dressing vacuum pump did not interfere with day-to-day routine activities. The preliminary analysis mentioned a $1,635 savings on the average when a participant was given a Pico dressing instead of an Aquacell. That average increased, right, when we targeted the analysis to only include high-risk patients. As aforementioned, the parametric analysis isolated each influencing factor and then determined that there's no recognizable patterns or correlations other than the dressing in regards to discharge time. That's kind of further evidenced in that the best outcome differences were also noted in those patients that were considered high risk. If indications of use were tailored to use the Pico dressing on these high-risk patients only, the cost savings would nearly double. We implemented recommended guidelines for our orthopedic center to apply Pico dressing in the instances of revision total joint surgeries, irrigation debridement surgeries, as well as dehisced surgical wounds. On top of that, a SWOT analysis was also performed on this improvement study. It's really to best identify its internal strengths and weaknesses, as well as look at the external opportunities and threats. When we were developing these indications for use, we understood the need to address the external threats as well as the contraindications for use. These included patients who traveled from a significant distance, mostly because the support outside of our network for these can be unpredictable, right? If something were to require intervention, it could be confusing and challenging for families to deal with, especially if they have no medical experience in their background. These dressings are becoming more popular as time and research and attention grows, but they're not a new product, and they're still not everywhere. The Pico dressing itself has been around for close to 8 years now, and the concept of negative pressure wound dressings has been around even longer. It wouldn't be unreasonable to think support for these dressings could exist outside our network, but the fact that we can't guarantee it, that all patients would return to an area where there are resources, it makes it as the reason why there's a contraindication. At the end of the day, we're also looking to improve and optimize patient satisfaction, right? The last thing we want to do is frustrate our patients with technology that they're unfamiliar with and then leave them on their own to possibly troubleshoot. Not to mention, a majority of our patients getting total joint replacements are between 60 and 80 years of age. I have each dressing shown in the previous slides. If you had any questions on what they looked like, again, I'm not live, so I can't hold them up and show you. But I do have a few relevant notes that I kind of jotted down from this project. So the Pico dressing attaches to the 6x6 centimeter vacuum pump via clear line. I've showed you that pump through a couple slides now. You've probably already seen it. This line is able to be removed from either the dressing or the pump by lure lock. So you can shorten that or connect that line to make it an extension so it can go in a pocket maybe or clip on some clothes or in a jacket. So the pump itself can be fitted to the included pant clip. And I displayed that in the photo. That's actually what you're looking at right now. We found through feedback and experience from many of the participants that they recommended this clip be redesigned by the manufacturer, Smith & Nephew. The critique was that it would frequently slip off their pants due to that loose clip tension. It just really wasn't holding anything there. So it became a headache for a lot of people. As you can see, the clip is also clear plastic. It's packed underneath the pump in a clear disposable container out of the box. So we also found that the staff that were responsible for opening the package and applying the dressing often mistakenly threw away this clip since it blended in with the disposable packaging. In addition to these little notes, the pump will automatically shut off after those 7 days. It won't be able to turn back on after those 7 days. So you can press that button all you want. It's going to be a dead pump. So the patients are told to throw that pump, throw the dressing away at home or at clinic, wherever they take it off. But the batteries are still good in the pump. So we found that a lot of people reported that they like stealing the batteries out of it before they throw it away, because there's still some good AAAs that they can put in a remote or something later. For those wondering, it's a common question, so I'll just address it quickly. The negative pressure for these is around negative 80 millimeters mercury. So a tourniquet's anywhere from 200 to 250 for the average blood pressure. So you can compare that and kind of have it in the back of your head if that came up. Again, thank you all for the attention, the opportunity to share with you. There is my email. If anything comes up, absolutely write it down, send me an email. I'll get back to you pretty quickly. If I don't know the answer, I could absolutely get you in touch with the research team for Smith & Nephew. I've been going back and forth with them over the last year to answer all my questions. So I'm not endorsed by them at all, but I can absolutely get you in touch because my expertise with this really is limited to orthopedics, and there's so many uses for this, but this is just a little glimpse of what I've been up to. So thank you again. Have a great rest of the conference.